So, if for whatever reason a patient feels that they can't afford a medication or they don't want to go through the hassle of applying for sponsorships and whatnot and coupons, manufacturing coupons, then these are going to be your options. I hate that I even have to draw a poor man's pathway, but just something to keep in mind. So here it is. Basically, the first house that we come to isn't even a house, it's just a lean-to, because that's how cheap these drugs are. And also because they cause weight gain, they're the only two that cause weight gain. And if the patient gains weight, they will no longer fit if you try to put it in a tent. So it's just a lean-to so that they can expand. So that is sulfonylureas and TZDs. Cause weight gain, cheap, been around a long time. Sulfonylureas is going to cause a little bit more weight gain than TZDs. On average, if you start insulin, you will gain 10 pounds in 3 years, and sulfonylureas will cause slightly less than that, and TZDs will cause slightly less than that. Another thing, obviously TZDs is going to be one of the last things you might try. Neither one of these is better than the other. They're just they're the next kind of most efficacious in lowering blood glucose and blood glucose control. But some people, sulfonylureas isn't on this list, but you could kind of keep it in your back pocket as maybe considering it before proceeding to insulin. The thing about sulfonylureas is, like I said, it can cause weight gain, and then it tends to stop working after about 2 years because eventually your pancreas stops responding. So, also it has a high risk of hypoglycemia, but insulin has a higher risk of hypoglycemia. So, it's like that's kind of a trade-off there, where if you're going to go to insulin anyway, sulfonylureas is sort of like a baby step to insulin. So those are very cheap. And then we've got a lot of other drugs that I haven't mentioned yet, and they alone definitely would never be used as monotherapy, and just kind of, they're things to try. And if you have certain goals, there's 3 of them that I'll talk about. And I kind of think of them as the bulimia tent because they cause a lot of GI issues. So that's one of the problems. Metformin obviously is going to cause GI issues. That's the number one reason people stop using metformin probably is the stomach upset because it prevents absorption of glucose in the gut. And none of these other ones will cause that problem, so if they have to stop that, then they can just go along this trail, no problem. If they are poor, they can go along this trail, no problem for these 2. And then we've got our bulimia tent, which I'm just going to kind of draw like this. It's like a tent. I don't know what a tent looks like, okay? We've got AGIs, which is alpha-glucosidase inhibitors. And the way this works is it prevents the production of amylase by the pancreas. So that prevents the absorption of sucrose by the pancreas. Remember, metformin is glucose, I think, and amylase prevents sucrose or not having it because amylase helps to break down sucrose. So if you don't have it, then you cannot break it down and you end up just passing through. So it can cause a lot of GI issues. In fact, 50% of people that take alpha-glucosidase inhibitors will discontinue within a year because of flatulence. Also causes a lot of diarrhea. So, this is actually not causing any kind of bulimia, but it's causing diarrhea and flatulence. Okay, but it will cause a little bit of weight loss in some people. So that, you could think about that too. Or you could do bromocriptine. This is going to be the next most stomach upsetting drug. It's a dopamine agonist. It's the only dopamine agonist approved for the use in diabetes type 2. And we're not even really sure how it works, but it seems to work with the hypothalamic axis in some ways, and but it does cause some stomach upset. And so you cannot use it. Let me So it will cause some moderate stomach upset, which I was surprised by. I don't understand the mechanism as to why that would cause stomach upset, but apparently it does. Also, obviously, you can't use this in pregnancy because dopamine inhibits prolactin, so that would stop the natural hormone release for breastfeeding. So you cannot use this in breastfeeding. And it's weight neutral, if you care to know. I'll go through and point out things that are weight gain, which just these two and insulin are going to be weight gain. And then I'm going to do like a weight loss pathway at the end. And the third one for this belly upset tent is going to be Cholcelevan. So I think of this as Cholesol. That's kind of like a butter that kind of goes around the bile and just it sends it right through you. And so that actually only causes mild GI upset compared to bromocriptine, according to the literature, which is surprising because this clearly has a direct effect on the intestines by preventing the absorption of bile. But most people seem to tolerate it pretty well. And obviously, its original purpose is to reduce low-density lipoproteins, so it's good for hyperlipidemia. Unless you have hypertriglycerides, then it is contraindicated. If you have ever had triglyceridemia of greater than 500, or any kind of pancreatitis related to hypertriglycerides. So keep that in mind. The reasons there seem pretty obvious, and it is. Oh, okay. So this one is contraindicated if you have ever had diabetes ketoacidosis, or cirrhosis, or IBD, or IBS, because it prevents absorption of sucrose, and that can irritate the bowel lining. So IBD, IBS, that makes sense. Not really sure why cirrhosis is a thing. Another thing about diabetes ketoacidosis, if SGLT2 TIs work at the kidneys, and if for some reason you are blocking the kidneys for whatever reason, that can lead to diabetes ketoacidosis because you're not allowing this drug to take effect. So if, like I said, these three have all been shown to be just as efficacious in lowering A1C as monotherapy, if you're taking SGLT2Is as monotherapy and you have any kind of like high stress situation that's lowering the blood flow to the kidneys, you could end up in diabetes ketoacidosis because you're no longer filtering, and so you're not getting rid of that sugar, and so you have problems. Okay, so that would be the poor man's path, and then you could, of course, then end up with insulin. TCD is already on this path, so that's kind of redundant. But we're skipping these three, which are kind of the three big ones that came out 2005, 2006, and 2013. And so I said we would go through a weight loss, goal-oriented pathway. And so how that would work is basically similarly, you would go through this way. How do I do this? I'm just going to make like just a smaller line for weight loss, and then you can go take a detour and go back. So weight loss is going to be pretty similar, but you could go to the bulimia tent to try and lose some weight. So basically, you've got metformin, that's good. Probably not the best though. GLP is actually going to be a little bit better if you're really committed to weight loss. Then liraglutide is going to be really beneficial. It's also approved for just weight loss without diabetes. It works really well, daily injectable. And then SGLT2 T2Is also help to lose weight. Of course, you have to have an appropriate GFR. That hopefully shouldn't be a problem. Then, actually, before you get to the bulimia tent, if you have some money, then you can try what is known as what's like something expensive. I'm gonna draw a boat. So this is a river, I I guess, a weight loss river. And this is a boat, because boats are expensive. And you can try pramlintide. And what this is, this came out in 2005 as well, along with GLP-1s. And it works by, it is just an amylin analog. And what is amylin? You may have never heard of it. Insulin takes a lot of credit for what amylin does. The pancreatic islet cells in the pancreas have beta and alpha cells. Beta cells secrete insulin, alpha cells secrete glucagon. But beta cells also secrete amylin with the insulin. And what amylin does is it inhibits glucagon secretion. It creates a sense of satiety. And it does one other thing that I'm forgetting. It slows gastric emptying. So all of those things can lead to weight loss, and it can actually also be used in type 1 diabetes. The only one of these, besides insulin, that can also be used in type 1 diabetes for type 1 diabetics that want to lose weight. So it's something that's rarely ever used. It's very expensive still, until 2025 at least. It's called Simlin. The generic is called Simlin because it's similar to amylin. It's an amylin analog, and so no one ever talks about pramlintide. I don't know why. I don't really know any of the risks associated with it. It seems like it would be pretty safe because it's just a natural thing that occurs when you eat anyway. Just a lesser known hormone. And here we go. That's kind of it. So pramlintide helps you lose weight. So first you'd want to do liraglutide, then you would want to do pramlintide. You could do metformin at some point. You'd probably just start with that and liraglutide, and then you could try pramlintide. And then the alpha-glucosidase inhibitor could help you lose weight. It's also going to make you fart, so you'll probably stop using it. And then all of these are just going to be weight neutral, so it's something that you could add on. Cholestyramine obviously would help get your glucose in check, and your lipidemia in check, and then the bromocriptine is just going to be weight neutral. Also, DDP4-Is is going to be weight neutral. I forgot to say, any of these would be options to lose weight. So this river includes all three of these, pramlintide, any of these, which AGI is going to be probably number one if your goal is weight loss. And then these are going to be, this is weight neutral, and then I don't know, I'm going to make the river go around TZDs because TZDs make you gain weight, but actually so does insulin, and insulin makes you gain more weight. So what I'm going to do is I'm just going to end the weight loss river at DDP4-Is, which are weight neutral. Weight neutral. So there you have it. This is how I think about it. To try and make it as simple as humanly possible, and for you to just see stuff and say, see many patients and just say, okay, that makes sense for them, that makes sense for them. And if people have specific questions, you can bounce around, or if you want to walk someone through this, you can do that too, where metformin is going to be number one, but then you've also got these two, which are actually really good and have several different benefits that I'll talk about in another video. And then you've got DDP4-Is, which basically works the same way as GLP-1s, or TZDs, which may prevent stroke but is contraindicated, may prevent stroke risk but is contraindicated in heart failure. And then you've got your insulin. And sulfonylurea is not really used anymore, but they are really cheap, and they used to be used quite a bit. And they have one drug that's available for pregnancy as an oral therapy rather than having to use needles, if that's a problem for pregnant women. And then TZDs have been around a long time too, so those are really cheap. These three are all generic, and of course these two have other uses, so that's why they're so cheap, because they're not really used in diabetes, but you could use them mostly as additive therapies. They're never going to be monotherapies. And you've got pramlintide, which can be used in type 1 diabetes, and this is weight neutral. And so yeah, glucose control, money control, weight loss, and that is how I think